Want the fastest working GLP-1? For half the price, Ro now offers FDA-approved weight loss injections cheaper, with results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss faster, confidence higher, price cheaper. See if you qualify at ro.co/TV.
Can you tell us a little bit about how endocrinology treats like metabolic conditions, or like what that commonality is?
Yeah, absolutely. So the endocrine system, right? It's actually a vast network of glands that secrete hormones. And these hormones are in charge of, they're almost like the master controllers of a variety of functions. And that can range from your metabolism to hunger cues to measurements like your sodium, potassium, your blood pressure, all the way to your bone health, your reproductive health. So it has many, many vast effects on your body and your entire system and many phases of your life. So, we really look at as endocrinologists, excess hormone, deficiencies in hormone, and then just the right levels of hormones. And when we have imbalances, right, for example, with your metabolism, that can lead to metabolic diseases or syndromes, right? So that's part of what we treat as endocrinologists. And you're right, a lot of us, a lot of people think we're just diabetes doctors, but we treat adrenal conditions, which are small glands on top of the kidney. We treat pituitary and hypothalamic conditions, which are, in your brain. And then we treat thyroid conditions, we treat diabetes, we treat PCOS, we treat insulin resistance, we treat many, many things. So there is a very strong intersection between metabolism and the endocrine system. And there's also a lot of hormones that are secreted from almost larger systems of glands, right? What we call the enteroendocrine system, or your gut. And, that's also responsible for a lot of hormone secretion that relates to hunger and hunger cues.
Wow. That's like the best thing I've ever heard anybody say. Like a little bit. That's short. Right there, ladies and gentlemen.
Definitely.
Right there.
All right. So I nerded out a little bit on your OAC, the Obesity Action Coalition lecture.
We are such
pudding. I still got that protein pudding.
Pat and I are in like marketing and support and operations, and we're like, doctors talking about endocrinology.
So you went over the criteria of PCOS, right? You mentioned the Rotterdam criteria. This might be a little bit too visceral, but I wanted to know, what is that specifically, Rotterdam criteria? And then what is the criteria used to diagnose PCOS?
Yeah. So let's start with what is PCOS, right? So polycystic ovarian syndrome, right? So we actually don't know a lot about the pathophysiology or what causes it, how things stem and kind of progress in the body. And the Rotterdam criteria is one of the criteria that we use to commonly diagnose PCOS. It's probably one of the most widely used. And really, it focuses on 3 components of what can make up PCOS, and you need 2 out of 3 to qualify for a diagnosis of PCOS. So we can kind of walk through each one. So the first one is menstrual irregularities, right? And this definition can actually differ on the point of time you are in your life. So for example, if you're a female who is 3 years after menstruation up to perimenopause, then, your definition of an irregular period can be menstrual cycle less than 21 days apart, or greater than 35 days apart, or less than 8 times a year. So really important to note if you're having irregularities in your menstrual cycles, and to let a doctor know, because that's one of the criteria. The second criteria is really relating to what we call hyperandrogenism, right? So higher levels of male hormone, either what we call biochemically or clinically, right? So biochemically, we would do some testing on your hormone levels to see if you have elevated levels of, for example, testosterone, or we would ask you about signs and symptoms of that, right? So signs and symptoms of excessive male hormone can be, for example, excessive hair growth, or what we call hirsutism in a male pattern distribution. So maybe on the back, chest, lower abdomen, acne, right? And for some people, even hair loss, right? So that's the second criteria. Third criteria is actually dependent on your ovaries, right? And really, you need imaging for that. So oftentimes people will go and get imaging for that to look at the follicle numbers per ovary, the ovarian volume. So this is, really done through imaging. And follicles are these small, really fluid-filled sacs in the ovary that contain and they release eggs, right? So they actually also produce a hormone called AMH. And that's another thing that we can check in lieu of this imaging, right? So that was actually a new criteria that was added. So you need 2 out of 3. You need either irregular menstrual cycles, clinical signs of elevated male hormone, or biochemical signs, so meaning on blood work, or the specific distribution or change in volume of the follicle number or ovarian volume that's maybe seen on imaging, or a difference in your AMH level or this anti-Müllerian hormone level that can be checked. So generally 2 out of 3. So that also goes to say that you can have regular menstrual cycles and still have PCOS, right? So sometimes that can be really confusing for people because they're like, well, I don't really have irregularities in my menstrual cycle, but I do have these other signs and symptoms. Or they might say, I do have, irregularities in my menstrual cycle, but I don't really know who to talk to about this.
That's so interesting. I got a question to build on that. Mine, I've just, I used to be so like, I don't want to talk about my periods, whatever. We're gonna let it loose. I might have been irregular ever since I got them, since I was 12. I would get them twice in a month sometimes, and I would go 2 months and get one, but they've always been irregular. And then I started to bleed in between as well. And that was due to polyps, we think, because it started to come back a little bit. But I wonder if, my doctor did the opposite. I took a blood test and it was negative for PCOS, but I wonder, with irregular periods being that irregular, is there anything else that it could be an indication of, and as well as like bleeding in between as well?
Yeah, so that's why it's really important. As endocrinologists, we co-manage PCOS sometimes with gynecologists because there are things that can cause, differences in your menstrual cycles, whether that's, the amount, intensity of bleeding that you have, the timing, symptoms like cramping, right? So we tell people to get screened for even things like fibroids, right? Which could maybe cause heavier bleeding.
Right. Interesting.
Yeah, I think I think that I never knew what to ask. Like, for me, like, my cycle would be short. Mine were short. And I also have a lot of pain when I ovulate. Like, I have to take Motrin and stuff, like, because it really hurts. And I had infertility issues, so I had like 2 miscarriages. And they kind of, but I always had obesity this whole time. And I was very much dismissed. I was just like, you should just lose weight. You should just lose weight. If you lose weight, it'll all work out. Just go lose weight, And I'm kind of in this echo chamber, like on socials and on TikTok, with the things that we talk about and hanging out with the doctors and all things. And I found that, like, I kind of thought that, I guess I was thinking things were changing way more than they actually are. Because when I went to do my yearly recently, my OB was like, so you're taking Mounjaro, like, why are you taking it? And I was like, well, I have obesity. I'm taking it for obesity, and this, my insurance will pay for it. You have to do a PA and all the things, and then he launched into that I should lose more weight and that I was not small enough. And he didn't ask me how. He was just like, and then he started telling me that I should be the same, like closer to what his wife's weight was, which was like 120. I'm not kidding. 120, 125. And because women have a smaller frame. And I said, I'm actually very tall and genetically just a larger human. Like, if you look at my genes and all the other humans in my family, and he was like, it doesn't matter. You should never, ever weigh more than 200 pounds, ever. You should never, ever. There should never be anything. Should never. I was like, and I am on the table in my
scrub
with this thing over my thing. And this man is lecturing me and telling me what I need to do. And then he was like, are you doing anything else? And I went, I do all the things. Like, I didn't want to be like, actually, I have a health and wellness podcast. And but like, I didn't want to get into it because I'm just there for him to check my parts. You know what I'm saying? But like, it just blew my mind that the audacity and the ignorance, like, none of that is actually true. We know that there are certain bodies, like, that are not going to be under 200 pounds, and that's not a bad thing, and that there are so many different things. But it was so, and he's young. Like, I was like, how? And I was furious. And I made a TikTok after, and I was so hurt. And all I kept thinking was, this is why people end up with diabetes that have obesity, because they get this kind of treatment, right? And they get this kind of, you know, I would say, like, I don't want to say ignorance, but I kind of do, because like ignorance just means not informed, right? Where he doesn't know, and he doesn't know how to talk to a woman, which is crazy because he looks at vaginas all day. So I don't understand, but it's true. It's my podcast. I can say what I want, but it's true. But he clearly didn't. And I am a very loud, obnoxious advocate. And I was immediately back to where I was 2 years ago, just taking it in and feeling like crap. You know what I'm saying? Because I didn't know to question my doctors. I didn't know how to say, help me understand this, right? I just sort of took it. And I have a lot of regrets because I wish that I had known about Victoza, right? After I had my son, because when all my weight came back and then I really couldn't get it off, I wish I had known. Maybe I could have had more children. I love being a mother. It's my favorite thing. And I, for whatever reason, like, didn't get that. I mean, I think this is sort of my baby now, so that's okay. But I wanted more children, but I didn't know. And I just want anybody in our listening audience, like, please take an opportunity to listen to this. If you are planning for a family, to know what questions to ask. And we're going to talk about all those things now that I'm off my soapbox. Sorry about that.
No, Kim, this is really important. First of all, I'm sorry you went through that. But what I will say is, a female in medicine, a woman of color in medicine, we are not heard always, right? And just as a woman, being a doctor, being of color, but just as a woman, and I would say even being a patient in the past, or even now, right? So I would say that we have to be advocates for ourselves. So you need to find a physician that is actually going to hear you, see you, listen to you, right? And believe what you're going through. Because you're right, oftentimes we are dismissed. And there's a second layer on top of that, which you mentioned, which is weight stigma and bias, right? Yes. So that is pervasive in the community, but also don't forget it's pervasive in the medical community. And we're trying our best, to educate not only the community, but doctors on how to approach weight, how to speak respectfully about weight, how to open that discussion for when people are ready, and also not to blame individuals. This is a disease that is not someone's fault. It's a disease, right? You need to understand that it's a chronic disease. It's relapsing, right? It can come and go is what it means. And it's progressive, right? And it's related to so many other disease processes, right? And I think the main thing is not to hold people at fault. I have countless patients that have come in and told me, that my cancer was blamed on my weight, sorry, not my cancer was blamed. What they were trying to say is that their problem, whatever their situation or their symptom was blamed on their weight. And then it was found out that they had cancer, right? Or that, their weight was used as a reason, just lose weight, you'll be fine, and then it was found that they had some other aggressive process going on. That we need to be very mindful of. We need to listen to a person's symptoms. Sure, weight, obesity as a disease is linked to 200 other diseases, right? And we understand the risks of that, but we also want to make sure that it's not just used as a scapegoat to blanket other symptoms or signs that someone may be having of some other process. So it's really important not to blame or to not do the due justice and workup that somebody deserves.
You want to know a hack to get insurance to cover your GLP-1 prescriptions? Here's the truth. Most people get denied the first time that they try, and insurance companies are betting that you're just going to give up. But you do have rights, and you can appeal not just once, but multiple times. The problem is the process is confusing and it's time consuming, and a lot of providers just don't have the bandwidth to be able to fight through it with you. So that's why I partnered with Claimable. It's an easy-to-use tool that helps you build expert-backed appeals proven to work. So don't give up on your shot at coverage. Exhaust your appeals. Go to getclaimable.com/plussides to learn more and use code PLUSSIDES with a Z to save.